Greetings, listeners, and welcome to the Care Table podcast, dedicated to educating and supporting family caregivers of aging loved ones. I'm your host, Amy Huddleston. Through insightful interviews from both industry experts and family caregivers, we aim to provide valuable perspectives and resources. Let's see who we're learning from today. Well, hello, Dr. Jason Hurst. I'm so excited that you're here today. Thank you so much for joining us. I read your bio, and I have to say, you are a badass, and I can say that on a podcast. I want to talk a little bit about what you do, but before I let you do that, I have to brag about you that you went to Georgetown University for your medical degree. You did your residency at Duke University. And I was so interested to see that you were actually the team doctor for the U.S. women's ski team for 7 years.
Something like that's about right. Yeah, exactly. Almost 7 years.
Okay. So very, very grateful that you're here today to talk to us about just kind of prep for surgeries and what people need to prepare for. So tell us a little bit about you personally and also just your professional life and anything else you'd like to share as an intro.
Sure. So I grew up in Maryland, actually. Met my wife when I was in med school in DC. And I went to Duke. Even though I'm from Maryland, I was a huge Terps fan. That was hard to swallow, going to Duke, but I battled through it. And then did my fellowship out in Colorado. That's where I got involved with the ski team. Then came back to Ohio. My wife's from Ohio. And joined a group that actually had another doc who trained at Duke's. That was great. Good connection. And that was back in 2009. And I kind of did a dual fellowship. I did sports medicine, which focused mainly on shoulder reconstruction and knee reconstruction, and then did an additional fellowship in joint replacement after that. So my practice has kind of evolved over the years. It started off as a lot of sports injury, and then now it's 90% of it's arthroplasty or joint replacement of the knee and the shoulder, which is a little bit unique because most replacement surgeons do hip and knee, and I do shoulder and knee because I had this dual training. So it's kind of weird. Not many docs in the country do that that combo. And so my practice has evolved. This is now my 16th year of practice. Joined a small, almost focused on arthroplasty, and then it's expanded to where we deal with all the subspecialties of orthopedics, from knee to hand to wrist to spine, everything. And that group was called GIS Orthopedic, started in 1972. And then about 2 or 3 years ago, we joined a big consortium of practices called Orthopedic Alliance. Now we're the biggest practice in Central Ohio, over 60 docs. And in the Midwest, it's actually over 250 docs. So it's a huge group. So it's been great.
And you have a lot of knowledge, obviously, if you have 250 docs that are working together to learn from each other.
Yeah, in terms of best practices, I mean, that's where the power is. When you have big groups, you can kind of pick and choose, what the winners are in terms of your practice patterns. And it just makes for a good cohesive group of peers that can share ideas and grow.
So you focus primarily on shoulders and knees, and I'm curious to know what percentage of the surgeries you do or your patients that you see fall in each of those categories.
So, I mean, there are more knee problems and shoulder problems, to be honest, in terms of that need surgery. So it's probably 60-40, maybe approaching 50-50, just because my practice has grown so much in the shoulder replacement world. But it's about, I would say, 50-50, 60-40. And it's 90% joint replacement. The other 10% would be things like knee arthroscopies, in non-arthritic joints, rotator cuff repairs, those kind of things. That falls into that subset of kind of joint preservation and trauma to joint. And then when you have arthritic disease, then you get into the joint replacement of knees and shoulders.
So I'm curious in the demographics of your clientele, like roughly how old are they?
So my shoulder population's a little bit older than the knee population, as you can imagine. And I would say from a our practice is about 60 to 65% Medicare, which is pretty typical for a primarily like joint replacement practice. You can imagine that's who we're getting at, people over 65. But it's expanding because implants are getting so much better. We're getting a lot of younger patients who have really severe disease that we weren't able to treat before, because the implants have gotten so much better. We're more aggressive to give people their life back earlier. I mean, I always tell patients it doesn't make much sense to mortgage your younger life for your older life, right? So,
Right.
like, don't suffer until you're 65, 70. We have good revision techniques or redo techniques that can salvage these joints, or if they do deteriorate in your 60s and they had it done when they're 50, or we can do revisions with much more success now than we were doing 20, 25 years ago. But the implants are lasting longer, so I think our revision burden is not going to be quite as high as we thought it might be because of implant survivorship.
So you said about 60 to 65% of your patients, though, are on Medicare typically.
That's right.
So, okay, so they're 65-ish or older getting these procedures done. So that's what I want to talk a little bit more about today, is because our audience is the family caregivers that are caring
Right.
for their older parents or aunts, uncles, family members. So in knowing you deal with a good amount of that population, let's talk about, there's obviously surgery prep that needs to happen. There's the procedure that you're going to do. There's advice that you're giving them. Let's talk about, what is it that I guess you find most challenging? And when you're giving these instructions to the patient, what is it that you're finding, they're pretty good at following, and then in some cases they're not so good at following?
Well, I mean, I guess I'll start with like the pathway, right? So let's say you have a patient who has end stage disease and they've tried everything, and you're going to go into you're making a decision to move on to surgery. I think the biggest hurdle for us is overcoming some of the misconceptions about what care is like in 2025, and some of the misinformation that I think is ingrained in patients' minds from the days of old. The average length of stay for a knee replacement back in the 80s was 6 days. Now the average length of stay is almost 6 hours. So we have changed so much. The surgery is still the same. It's still a knee replacement. I mean, you can't really make it less invasive than that, right? I mean, sure, smaller incisions. It's all about the care of the patient. So anesthesia is better. Our expectations are greater. We encourage independence, and because independence creates function, right? So activity creates function. So going to a nursing home or inpatient care post-op is the worst. We hate that. We like people being at home. So a lot of times you see these.
Tell us why, because I love that you feel that way. Tell me why.
I mean, there are a myriad of reasons. I think the number one thing is independence, right? Is walking around, taking care of yourself, is activity. It helps in every single part of the postoperative window. Less blood clot, less pneumonia, less bowel issues, right? All those things, being up and moving, help the patient recover. They ambulate quicker, right? They get back to being functional much faster. Now, that's number one. There's less infection. Sick people go to nursing facilities and rehab centers. All the bugs in your house you've been with for years, right? So it's a safer place to be at home.
Okay.
Wound issues aren't as much of a problem anymore because the way we close wounds is better than it used to be. And I'm not saying that there aren't patients who need inpatient care, because there are. There are people that are really debilitated or have absolutely zero assistance. They live alone, and they can't go home. I'm just saying that for the majority of patients, we oftentimes have to encourage them that the home is the best place for you. And we are also a believer in outpatient physical therapy. Getting dressed, feeding yourself, getting in the car, walking into the therapy, that's therapy in itself. So
I agree
having
100%.
in-home therapy, of course, patients might need that. If they live in West Virginia in the hills and they got 15 steps to get to their car, yeah, that might not be great. So you have to get inpatient therapy, but getting outpatient therapy is the best. There is definitely a significant patient population that needs some in-home care. And I think that's where like in those patients, it's got to be really good, you know. And I think that's where we help to navigate the patients through that.
Wait,
I
I
think
want
one
to
of
ask
the
about that. So I love that you want to get them home. Let's talk about when they are, or when they're at home. Let's say you said it's 6 hours. I go home. Are you recommending I start going to outpatient physical therapy where I'm going to drive, obviously, probably need to be driven, but that I do that starting immediately, or do you
48 hours,
recommend, oh, okay, but
within
not
48 hours.
therapy coming into the house first?
So the best case scenario, regardless of age, would be home outpatient therapy every
Wow.
time.
Wow.
So I don't care whether you're 55 or 85. That is the best. Now, obviously, the older you are, you're obviously going to have a higher percentages of patients that might not be able to, um, get out of the house that quickly. However, the vast majority can. That's in the patient selection, number one. Number two, if you're 85 getting a joint replacement, you got there for a reason because you're healthy, right? And you're active, right? If you're 85 and you're not healthy and not active, you're probably not getting a joint replacement. You know what I mean? You know, these patients, they select themselves out. And so I don't think we had to do a lot of encouragement to let the patients give themselves more credit that they can do it, And so a
Do
lot
you
of them
ever
have
also,
fear.
do you meet people too, though, that are in that bucket of I'm 85 years old, but I've not been very active and I'm miserable, and you're concerned about their recovery, so you say, I don't think this is the right move?
Oh gosh. I mean, I think that is the art of medicine, is not knowing when to say yes, but knowing when to say no. They have a disease pattern that would warrant a surgery, but you have to look at the whole picture. You can't just say bad knee, get knee replacement. You have to think of the whole picture of the patient, and you got to think of, where their headspace is. Do they have some help? Are they healthy enough? And to help make that, it's a joint decision between, no pun intended, between you and the patient. But you have to be able to help direct the patient through this battlefield of getting through a surgery.
But I'm so happy to hear that you do that, because I think what happens, I don't know if you've ever read Being Mortal. Have you ever read that book? It's
No.
an excellent book, Atul Gawande. But he talks about, when doctors are first trained, you're trained to just fix everything. That's medicine. And he says, though, what we aren't trained well to do is to look at the full picture of quality of life, and does this make sense in the treatment. And so to hear that, my heart is happy, because it's over the years when we were dealing with a lot of people aging in their home, sometimes we would get a call and it would be an 86-year-old client, and they'd say, I'm scheduled for a colonoscopy. And I would think, why are we doing that for an
Right.
86-year-old, to put them
Right.
through this difficulty? Because what are you going to do
Right.
if you find something?
Correct.
So
No,
I'm
no.
really happy to hear that that's a mindset in your practice, is like, we're going to make this decision together.
And I think, like, when we teach a lot of residents and fellows and budding med students, and as a surgeon, I think that probably one of the the recurring problems with surgeons is that a lot of them get a little bit out of touch with how they treat people, because we're fix-it people, we're technicians, but your patients are so much happier and they listen to you more if you make more of a connection with them, and you listen to them, and you talk to them, and you go through the other side of medicine, not just the treating the disease part. And I always make it a point. I don't know where I got this from, probably from a great mentor. You know, it's not necessarily how much time you spend with patients in the office, it's how you spend the time. So, like, I always sit down. I sit down and talk to patients. I don't stand by the door. I don't stand at the computer. I always sit down. And whether you sit down for a minute, they feel taken care of, just that you actually sit down and take the time that you're listening to them. So those little things make a big difference in building trust and making the patients feel comfortable that you're not just going to throw a joint in them and on their way, you're actually taking care of them. And because one doc used to tell me that, yeah, you're married to your spouse, but you're also married to your patients the day you touch them, and you can't divorce that. So you got to own it and embrace it. So
I'm just curious, since you've been doing this for what, 16 years, but do you think you had this same mentality when you first started?
I mean, it's kind of like drinking from a fire hose when you first start. You're like, you don't know what you're doing. I mean, you know how to do it. You
Mhm.
just, you're building your practice patterns and you're thinking about everything. And when those things become rote in terms of like, you know, exactly like, when do I see him back in the office? What am I going to do? Like, what are the logistics of my practice? What exact medicines am I going to treat? What are the hurdles that I have to overcome in my community? Once those become figured out, I think the other things become more in focus and easier, you know? And, in the beginning, I think you always, the more touch points you have with the patient and the more you interact with them, the more patience you get. So I think you have to adopt that kind of mentality early to be successful and to have a big practice.
So I've been helping my 88-year-old aunt who's going through a health situation and been taking her to the doctors. And I've been trying to say to her, okay, we only have 10, 15 minutes with this doctor. So let's kind of make a list of what we're hoping to accomplish here. So because otherwise I feel like she'll, go off on her stories. And so I would ask you, what is your advice to kind of a family caregiver? What do you feel like is like the ideal appointment that you have with a new patient or a patient that's considering surgery? What information do you want in that time frame from them?
Well, in the world of joint replacement, I want to know what they've done. Just because you may have severe arthritis and you might have the indication for replacement, there's always room to try other stuff to see what sticks. So you want to know what they've done. I want to know what kind of medications they took for their arthritis, what kind of injections they may have had, what kind of therapy they have. And then that's the intervention part. And then I also want to know how it affects them. One of the biggest things I see is, you know, sometimes patients say, "Oh, I'm okay. It doesn't bother me that much." And then the daughter says, "Mom, you won't even go to the grocery store anymore." So having someone there to kind of build the whole picture of how it's affecting their life um, is really helpful. And yeah, I think the older the patients are, the more they need a little bit of someone to help them navigate, and build the whole picture for the doc.
It's overwhelming. And I think it's really, I mean, I've been going with my aunt to just say, I'm going to write down everything the doctor's saying because it's hard to remember all of those things as
It
well.
is.
Yeah.
It is, and it can be overwhelming, but I try to simplify it for the patient, and try to put the treatments in buckets, like, what did you do from a conservative standpoint in terms of what minimal intervention, like injections and those kind of things. And then we talk about surgery. So try not to overwhelm them with all those things. And when we schedule a patient for surgery, we also don't flood them with a ton of information early. We say, it's like getting on an escalator. Step on, we're the escalator, we'll take it to the end. And we'll feed you information as it goes along because it's overwhelming. You'll tell them everything. And a lot of times, they only focus like, oh my God, oh crap, I need a surgery, and then they get blindsided, they get like blinders on and nothing else gets in. We're talking about blood clot prevention, infection prevention, and when you need your pre-medical clearance and, oh, you might need this post-op, that just over their head because they're just like, oh my God, I need a surgery. So you
Yes.
have to be able to feed the information, titrate it in so that sticks.
How long roughly when you discuss with a patient and you say, okay, we are going to go the surgery route? What's the timeline from when you make that decision to when the surgery happens?
It So just from a pure scheduling standpoint, it's very cyclical throughout the year. So like right now, if someone came in to see me and they want to have it done, it'll probably get done within a few weeks. Um, and when it gets to the end of the year, it might be 6 weeks, 8 weeks, because things fill up at the end of the year, deductibles reset. Not much of a problem for Medicare patients, but for private payers, patients want to get in before the deductible resets on January 1st, which is the bulk of the patients. But typically for us, like a safe window, I mean, of course, we've done some were like, oh my gosh, you have a problem, I can get it done the next day if it's an urgent thing. But traditionally, it's a couple weeks. We have to get pre-medical clearance, and that difference per patient. Do they see a specialist, or they have to get, renal clearance from their kidney doctor? They need to go see their cardiologist to get checked out, pulmonologist, whatever. We do our own independent medical clearance through a different group that just takes care of pre-surgical patients, so they know the whole process. Primary care doctors doing your medical clearance is okay, but remember, they're not going to be the doctors there taking care of you post-op if you have to stay overnight, or these specialists, they just take care of the surgical patient. So we believe in it wholeheartedly, because they find things that are specific surgical risks that maybe would be overlooked by the primary care doc, or because they're just not in that space. Their primary care doctors, not necessarily pre-op surgical doctors. But that starts there, and then patients have to schedule their post-op therapy. So that we have to, and for us, our catchment area is so large, they're not all going to our therapy. They live in Lima. They're not going to come down here. They're going to find a place in Lima, and we try to give the patient the freedom to go where they trust. And the best references for therapy really isn't me. It's other patients, So talk to family members, talk to your community people. Where did your friends like to go? So we try to give them that freedom to help kind of get them vested in the planning process.
And you're saying that you can't have that surgery scheduled unless that therapy is also scheduled?
Well, I mean, it happens during the process. So we schedule it. We pick a date. We kind of pick a date. Let's say if I saw a patient yesterday or today, and I'm scheduling them for, September 15th, a month out. I say, okay, this is your date. You got to schedule your therapy to start on the 17th, and we'll fill in the stuff that has to be done before, like the initial. We do a pre-op therapy evaluation for every patient. We do a pre-op medical evaluation. We do a pre-op DME visit where you look at equipment you might need for post-op. So we handle all the pre-op. Just that post-op PT, we kind of put that on the patient to make sure they find the place they want to go.
Who helps get them the durable medical equipment?
Our office.
Okay, so they'll help arrange that.
We have like a menu, a catalog of sorts of different types of things that some are covered, some are pet cash only. But like, for example, like their insurance companies used to cover like those awesome ice machines for the joints. They don't cover them anymore. So we help get them those things. There are cool pain devices that patients can get. We believe in pneumatic compression devices for lower extremity arthroplasty. So we really encourage that to help prevent blood clots. There are nutritional bundles for patients that are nutritionally deficient. We always do a nutritional panel on all our patients and help direct them to that.
Okay. So, what is covered? I mean, do you know? I don't know if you can answer that, but I am curious to say, you're telling me the ice machines, are those private pay now?
They are, yeah.
And how much are those usually?
It depends on the kind you get. I mean, $100 to $400.
Wow,
not terribly expensive, but and then there are these electromagnetic pain devices that a lot of patients have liked to use. They're a couple $100. Walkers and canes are really cheap. And we provide those, and compression devices, $150, those kind of things. So there's definitely costs, but everybody's a little bit different. Now, some people think, you know what, I don't really want the nutritional bundle, and they can, go get it from somewhere else, or just change their diet, or we help navigate them through that.
Are those actual meals?
No, they're actually, so there was a fantastic study that won the Coventry Award, which is it was called the Ranawat Award, pardon me. That was a nutritional supplementation pre-op and post-op for joint replacement patients, and what it did in terms of quadriceps strength and function post-op. And there was a vastly significant difference in patients that did preoperative nutritional supplementation and continued post-op. What happens is patients that have osteoarthritis, they are in a catabolic state before surgery. What that means is they are automatically nutritionally deficient off the bat. Okay, you add in the stress of surgery, and they go even further into a catabolic state. So if you can get that curve up before, then that stress on the system isn't as great if they have nutritional supplementation. And that is really across the board. The original study of that was actually done in GI surgery years ago, and it was applied to orthopedics, about 5, 6, 8 years ago. So it's pretty profound. We recommend it for all of our patients. So if they can do it.
And what is it though? Are they actual vitamins you're saying, or is it food?
It's actually a shake. I mean,
it's a shake. Okay.
Yeah. So nutritional bundling. It's essential amino acids and protein and supplementation. It's mostly protein based and amino acid based. And the formulation is different pre-op than it is post-op. And then there's a day of surgery drink that's high in carbohydrates to help them.
Oh my gosh. I'm just cool. I had no idea you're doing that, but I think that is so phenomenal. And I hope that most of them are taking advantage of it.
Yeah. I mean, it's really cool.
So tell us, okay, what I'm curious about is obviously you're giving them all this information. You're giving them
I'm sorry about these beeps.
No, it's okay. It's okay.
Of course. Actually, I think it's a text of all the kids that are leaving for college. I got to get rid of it.
I know. And I'm like, it's all right. No worries. I'm trying to
blown up.
I know.
Sorry.
So we're talking about obviously the plans that people are given. There's a lot of information. What I'm curious is how many of your patients are following your advice and how many do not?
I think the majority do. I think when there's cost involved, I think some patients don't follow that advice. They get concerned about that, which is understandable. Probably one of the biggest issues is pain control. Patients don't really they don't like to take pain pills, but they have to. I have to encourage them to take those pain pills in the beginning, because if they get stuck in a pain crisis, then it's an issue.
I totally agree with you, because it's like that just spirals, it gets out of control, and it's hard to get that back under control. And I'm guessing you also have people that are really worried about becoming addicted to something and they don't want to take it to manage it.
And there have been studies on that, and taking the pain pills for pain in the early post-op period has a very low addiction percentage. It's when it goes beyond the early post-op period. It is a concern, and there was a study also done looking at after joint replacement. I think it's less than 10% that patients use narcotics after the 3rd month, which is a problem. So that is the push to reduce the amount of narcotics that patients use. So the use of narcotics before surgery is really the problem. So patients that come on into the office and they say, "Oh, I'm taking Percocet for my knee pain," I tell them, I want you off the Percocet 3 months prior to doing the knee replacement.
3 months.
If you are on narcotics within 3 months of doing a knee replacement, you're more than likely to be continued those narcotics 3 months post-op. And the control of your pain post-operatively is harder if you're on narcotics pre-operatively. You build a subtle tolerance to it. So it's a problem. And so that's why this whole concept of a multimodal pain strategy is important now. So using things like anti-inflammatories, non-narcotic pain control helps reduce your narcotic load to the point you can get off them easier. So, and we have all of our patients sign a narcotic contract that, hey, at 3 months you're off and you're not on it anymore. We have to kind of take the reins sometimes and be like, no mas, no more. You got to come off it. You got to go cold turkey. Yeah. And what happens, they don't want to believe it, but in those patients that are having a problem with narcotics, the pain doesn't go away until you're off the pain pills, which sounds counterintuitive. Because in order to get off the pain, in order to have the pain go away, you have to get off the narcotics. Narcotics reduce your pain, but your brain is smart enough to make more opioid receptors. Then you have to give yourself more to block that pain receptor, which is stimulated by your pain stimulus. So you got to get off the pain pills so then you can reduce those opioid pain receptors in your brain that you're upregulating because you're on the narcotics. That's why you get resistant to narcotics. So you got to
And
get
so
off.
you're saying, you said to me, and just remind me, you're basically saying if I stop taking my Percocet for 3 months prior to my surgery, I get my surgery, and then I'm more likely to use it again or not?
Well, it depends on what patient population you're talking about. But if you're on narcotics pre-op and you stop it pre-op within that 3 month period, you are going to be less likely to have to stay on it beyond that 3 month period post-op, because you'll be able to treat your pain better with less narcotic, because you're washing out your narcotic resistance in that 3 months. That's the concept.
That's
So
phenomenal.
patients that are on it beforehand need much more of it afterwards. If you're needing a narcotic to treat your pain, your arthritis pain, wait till I do a surgery on it. You're going to need more than that.
Right.
Those two Percocet that aren't going to cover now the surgical trauma that's causing pain. So we got to get you off the narcotics pre-op.
Because basically you're saying you've got to get them off so that you really can assess what pain level they're at.
Correct. And you want to be able to
Okay.
use those pain pills for surgical pain, not for this chronic pain crisis that they think they're in before pre-op. So you got to get off
So,
narcotics.
okay. So if they're doing that, then you're talking about, though, if the pain management is one of the most challenging things that you deal with as a physician, what do you mean by that? Like, is it because they're not following your instructions? Is it because they're not being honest with you about pain, or maybe what is it? Why do you say
So
that?
in the group that takes too many pain pills, they're probably not being honest with us about how many pain pills they're taking. So we have to keep encouraging them to, hey, get down off the pain pills, get that, switch from the higher potency ones to the lower potency ones. And we help navigate them through that. The other side of the coin is the patient that thinks they're tough and they can handle it, and then they don't take their pain pills. So those patients tend to they struggle in the beginning, and I'll tell you who it is. It's the 55-year-old male who thinks they're tough, they can handle it, they don't want to take their pain pills. I'm like, hey man, your knees getting stiff because you can't get through therapy because you're not taking your little pain pill, and we can help get you down, but you got to take it a little bit in the beginning. There's the issues of not taking enough and taking too much, is that a lot of them aren't kind of listening to us in terms of how to take them appropriately.
Well, I think you just said an interesting thing is if you can't get through your physical therapy, you're not going to get better. So if you're that
No.
uncomfortable, and I'm curious, in the post-op, do you get communication from the physical therapist that's telling you, yes, they're progressing, no, they're not? So how do you not have an idea of how they're doing?
I mean, we do. I mean, it's variable on the therapy practice in terms of what their communication is like. I mean, with our practice, and we use our therapy, I mean, obviously it's kind of like our own eyes on the patient. So our communication is awesome. I mean, I get texts and emails from therapists weekly, daily, on patients that might be struggling, or even those that are doing great. We get feedback. So I think that is helpful for patients to go to therapists within the practice that they choose to have their replacement. But if you can't do it, we do get updates. The problem that I see a lot that's changed is, in order to meet certain guidelines for reimbursement for a lot of these therapy offices, a lot of the notes have been, a lot of them are EMR generated notes. So they're kind of like very robotic to a certain degree. There's not much discussion. And before, it used to be a very nice note that said, they were very specific to the patient and told them exactly how they're doing. Now it's just not, the information is there, but it's not as conversational as the old notes used to be, 10 years ago. And that's where
So EMR is electronic, I'm guessing, medical record?
electronic medical records, which is in
Okay.
medicine, top to bottom. So, and
Okay.
EMR is terrible. I mean, but they accomplish a certain goal, but from how we communicate back and forth in terms of truly discussing patients, I think that's where some of them are lacking. They're getting better, but I used to like the old notes that just were a doc dictating into a system, or typing in a note, or writing a note, for God's sake, and you'd see exactly how the patient's doing, rather than some bullet point generated by some click boxes.
And this is because of insurance, you're saying. So it's kind
A
of
lot of it is, yeah, and just trying to, because in the physical therapy world, I see these notes that are generated, and they're hitting certain codes, and these little bullet points or check boxes are just there to satisfy those requirements for billing, and I think the communication is lacking in some of those notes. But
Can you talk a little bit about, I mean, obviously Medicare laws have changed over the years, and I was just surprised when you were sharing what, like the ice machine and the walker and all of that. A lot of times you're saying people are having to pay privately for these out of their pocket. And I'm curious, where do you see, or do you see the laws changing soon? And if so, is it going to be more beneficial to the patient or less?
I mean, I think they're always evolving, the Medicare regulations. I can tell you from the side of a surgeon and from a facility standpoint, what's changing most is site of service. So, for example, 8 or 9 years ago, or I actually call it, 10 years ago, Medicare was all joint replacements were what we call inpatient only. They had to go to a hospital for Medicare to cover the joint replacement. With the Affordable Care Act, just post the Affordable Care Act, they went off of the inpatient only list now to where joint replacements could be done at an outpatient center, and Medicare would reimburse that center. So that's evolved. So knees and hips and shoulders kind of slowly came off of that, where they can be done at a private outpatient center, which is huge for the patient. They don't have to go to the hospital. And now revisions or redos, I think that's going to be the next thing. Maybe they'll start coming off of the inpatient only list, and they can be done as an outpatient in certain scenarios. So I think that's the biggest things we're seeing is site of service in our world. The DME world, I'll be honest, I mean, that's a whole nother space that is like, I don't know much about, I probably should, but we have a DME coordinator that knows all those rules. Those change pretty regularly. As certain types of codes that are for certain devices definitely change, and what Medicare is going to pay, what they're not going to pay for.
Okay.
And that happens throughout the year. Things just change and change and change.
Wow. Well, I will have to look into that, because I do think that's helpful information for people to understand, and just like you're saying, the cost is a consideration when people are going through this. If they're having to pay a decent amount of money for all the supplies they're going to need afterwards, that's a concern for some people.
It is.
So,
It is.
yeah.
It is.
And it's to understand,
especially on fixed income when you're retired.
Yeah.
It is an issue.
But I understand why these things are changing, just because obviously our population's living a lot longer than they used to. So there's only a certain amount of money that's going to cover, everybody who needs the help. And as I'm sure your patient's age is getting slightly older every year of who you're taking care of.
Yeah, it does get a little bit frustrating because, when you have these interventions that help people, whether it's in the DME world or whether it is surgery, for example, the biggest problem, I think, are some of the predators out there selling certain interventions, and patients are quick to try to jump on them. They'll pay $3,000 for a stem cell injection into their knee, but they won't pay a $50 copay or a co-insurance to have their knee replacement done, which is really what they need. So, and it's really frustrating. You see these advertisements on TV, it is totally predatory on these patients looking for some, snake oil, and it's really hard to control it, from a policy standpoint, and it just drives you crazy, to see that patient waste all this money on stuff that doesn't work, and yet we know something that works, and they don't want to spend that money. So it's like, oh, God, if you can just get to them sooner so they don't waste their money for this, and they do put their money towards something that actually works,
Well, that's good advice for people to hear. So it sounds like they at least just should make the appointment, go see the surgeon and hear what your options are.
Yes. See a doctor, see a surgeon, get the real advice,
And it sounds like, too, come prepared with everything you've tried so far.
Absolutely.
Before you're going to do anything else. And then we'll talk about what your options are, and you can decide.
Yes.
Okay. So is there any other advice you'd give to family caregivers as far as the surgeries that you're seeing and the post-op? It sounds like pain management can be a little bit of a challenge, but making sure they're going to physical therapy, I know, is so key to get that recovery. But is there any other advice you would share that you feel like, just even in your patients in general, that you would wish that they were maybe a little bit better at?
I would say if you have an older patient and you are the caregiver, um, know what they can do. Okay, so you have to really know the limitations and come prepared for that. You know, if they need the help, you have to be prepared to help take care of your aging, parents or loved one. So you have to be realistic about what they can do. And because like you said before, there are different levels of postoperative care. Obviously the best is the independence one and being home and going to outpatient therapy, but that's not for everybody. So you really have to know what your loved one can do, and so that we can help direct you on where to go. We have great case managers at the hospital that can help navigate you through whether do you just need home health and therapy, or do you need, to have
Home care. You need
home
home care.
care, or do you really need an inpatient facility? And so, and there are metrics that have to be met to qualify patients for different levels of care. And we can tease those out in the hospital if they come in for that. But it'd be really nice to know that up front.
Okay. And I am curious, this may not be in your world at all, but do you have any recommendations when people are looking at an inpatient? They have to do the inpatient care. They have to go to a short-term rehab stay in a facility. Do you have any recommendations for families on how best to choose one? I have some suggestions, but I would love to know
I
what you
mean, don't go to one.
I know.
I mean, that's a real recommendation. But I mean, no, I think you got to visit. I think the patients have to really take ownership of it and go visit the centers themselves. And like I mentioned, we don't visit them that often. And I've given talks and presentations at them, but I don't know what the experience is like. You have to talk to people that have been there, and get information from the people that you know in the community, because every community has these facilities. And with our geographic area being so broad, we don't have knowledge of, like I said, Lima. We don't know what they're like in Lima. We just get feedback from the patients, and that's good, but the patients have to do that themselves. And I think visiting is great. I always tell people if they need to go to a facility, visit, talk to them. And a lot of times, if you like it, they'll reserve a bed space for you. And so you can go directly into these places. So
And it'll be ready. But
be ready
I
for
think what you said is so key, because I think family caregivers need to understand that if you go to those facilities, and they exist for a reason, but if you go there, you're definitely more likely that your loved one is going to be in that bed. They're not going to move near as often. They're not going to be as happy because it's not, the warmest, friendliest environment.
it's not. Food's
So,
terrible.
yeah, if you could get them at home where they're already in their own space, which everybody loves, but you are going to get up and go to the bathroom more likely.
Correct.
And because
100%.
if you're in the facility, sometimes you're going to wait. I mean, and no fault of their own, but if you have one person that's managing the entire, hallway, you can't go to the bathroom in a timely manner. So you really want to think through those things. I think sometimes the adult kids are thinking, I don't want to have to worry about this. This is the plan we're going to go with, but try not to, would be
It's the
my
fear.
advice. Try
It's
not
all
to.
about fear. I mean, and you hit the nail on the head. When you're in a facility, even if it's an inpatient rehab, which is better than a skilled nursing facility, but they're only going in to see you 2 or 3 times a day for therapy. That sounds like you're doing a lot, but in reality, between those, you're not doing anything.
Nothing.
So you're sitting there watching, Maury Povich on TV,
Right.
like you're not.
No.
So, but if you're at home, you get up and get your own glass of water. You help make dinner. You get up and go to the bathroom. You may even do a little bit of laundry. You might go to the mailbox. So all those things are what help you move. And so, yeah, I mean, we're on the same page. I mean, I think going home is the best thing.
I think so too. So is there any other advice you would give to family caregivers to say, hey, other than you, it sounds to me from what you shared, it's best obviously go see a doctor first. Don't try some other things. At least talk through your entire plan. Come with a complete list of what you've tried, what your concerns are, and be honest with what you're capable of doing and not. Maybe bring the daughter or son with you. And it sounds like you got to follow the plan that's being recommended to you. Be honest about your pain. Pain management is important.
Huge.
Go to outpatient therapy also would be first.
Yes,
Okay.
100%. And I will tell you, I think, tell us tell us about your fears. So, and your concerns, because we do this every day. We see thousands and thousands of patients, but everybody's different, and what they're concerned about is different. And so we want to help alleviate those fears. And so that way, that the only thing that, fear is the drain, right? So if you're concerned about all of these things, it distracts you from what you should be worried about, and that's your knee or your shoulder or your hip, so I want to take care of all those things away from you. That way, all you got to focus on is how you're doing with your knee, going to your rehab, and focus on that knee. You know what I mean? That's why I tell patients they might need some time off work. And like, well, I really want to go back in, 2 or 3 weeks. And I'm like, hey, but your knee needs you for the 6 weeks. Don't let things distract you from the thing that's going to be with you forever.
Yeah.
And everything. The more you do in the beginning pays off at the end. So if we can help alleviate those fears, that's what we're here for. To talk you through the process.
I love hearing all that, really. I think it's so great that you're also looking at the holistic approach. You're looking at the nutrition, you're looking at the post-op recovery and the pain management. And it sounds like you're really doing an amazing job with these patients. And so if we could just do our part and follow your advice, then it would make your job a lot easier. So it's great. It's everything that you just shared was really helpful. Is there anything else you'd want to share with family caregivers before we wrap up?
No, I think from a patient perspective, you need to take ownership of what you're going through. So be vested, that's number one. And then number two, I think from a caregiver side is help them through this time. Be with them, hold their hand, make sure they're comfortable in getting through it, but encourage them to be independent while they're going through it. Because joint replacement and these kind of surgeries are not done for a patient to convalesce and recover passively. It's an active process. So while they definitely need help through this, alleviate their fears and make sure you can help them be a vested partner in getting themselves back to living and back to doing what they want to do, and recover what arthritis took from them, right? Get that activity and those things back.
I think that's good advice too for the caregiver, is to just make sure that the patient or their loved one understands just what the instructions are. And sometimes I feel like they need to be reminded of it daily, and also what you're working towards. Like, you're working towards feeling better and moving. So this is why we're going to do these things today. They need that encouragement and reminder. And if you're not able to do it, I obviously am a huge proponent of home care. So the therapy is great, but if you need a caregiver to come in that's a non-medical caregiver, they're the ones that can drive them to therapy. They can encourage them to do the exercises. They can make sure they're eating well and doing their nutrition and taking their meds on time. All of those things can help if the family can't do that. So
correct. They're a surrogate for that help, for
yes,
sure. And it's huge. And a lot of patients are going to need that,
Yes.
So especially as a lot of these elderly folks don't have family around, and they need those surrogates there to help them.
So that's a good piece of advice as well. But you're a rock star, and I am so grateful because this was very interesting conversation. I know this is going to be helpful to people, and I can't thank you enough for taking the time to talk.
Anytime. You're welcome, Aim. Take care.
Yes, thanks. Have a great day.
You too.
Thanks. That's a wrap for today's episode of The Care Table. Thank you so much for joining me. If you found this information helpful, would you like, subscribe, write a review, or share this episode with someone that you feel could benefit from hearing this information? I'd sure appreciate it. If you learned of anything during this podcast as far as books, resources, or products that you might think are helpful, be sure to check out the podcast show notes for links to access that information. A friendly reminder that this is not medical or legal advice. This is just information. Consult a professional for your own personal situation. I ask that God would bless you with the wisdom, the courage, and the strength that you need as you're navigating this caregiving journey. And I want to remind you, you are not alone. I appreciate you joining us today. And until next time, stay strong, and I hope to see you at the Care Table.